I'd like to welcome everybody back today, Alabama Care. And we have the pleasure of having Mrs. Sonia Cleckler, who is a speech language pathologist, and Dr. Carrie Overschmidt, who is an audiology specialist with us today. And we are going to be talking about Better Hearing in Speech Month. And at this point, I'd like to hand it back over. Mrs. Cleckler, if you would introduce yourself.
Hey everybody, my name is Sonia Cleckler. I am a speech language pathologist. You will also hear me refer to that as SLP or speech therapist. And I've been practicing for 21 years, 22 years this August. Graduated the University of Montevallo. I have 4 children with a variety of ages 6, 12, 16, and 21. And have a brother with special needs. Severe cognitive and physical special needs, although he's not the reason I decided to become a speech therapist. And a very, very supportive mom who gave me really good modeling of how it is to raise a child with special needs. So initially working in the therapy field was the last thing I wanted to do. I have worked in the school system, skilled nursing facilities, outpatient, and inpatient hospitals. And now I work with Children's Rehab Service of Alabama in the state office as the program specialist for speech language pathology. So now I'm more policy and procedure and trying to make things work in the real world for our speech therapists that are out there doing what they do for our clients.
Now, are you originally from Alabama?
Yes, I am.
And we always like to ask, football is huge here in Alabama. So do you go Roll Tide or War Eagle?
War Eagle.
Now, you mentioned that, why did you decide to become a speech therapist? Was there something that really pulled you there to the field?
There actually was. After everyone said, oh, you need to go into therapy and you need to work with people with special needs because you're so good with your brother. And I said, that's the last thing I want to do. I thought I wanted to work for NASA and work in a cubicle and not talk to people. And then I learned that I'm not good with math, but we had a child at church and he was neurotypical until about the age of 2, and he developed spinal meningitis. He almost died from it. And he was in a special Sunday school class with my brother, and he had lost a lot of his speech ability, and he was really trying one Sunday morning to tell me something, and I couldn't understand it. And he was trying and I was trying, and we were doing all the things that we could figure out. And in the end, when I figured out what John needed, it was too late. He needed to go to the bathroom. And right then I thought, of all the things in the world, you should not be able to tell somebody that you need to go to the bathroom. I mean, it's a dignity issue. He knew he wanted to go. He couldn't physically go. I couldn't figure out what he wanted. And so that was the driving force behind me wanting to be a speech therapist. That was it. It's everybody should be able to make their most basic wants and needs and feelings known. So it was actually my John that did it instead of my brother Yancey.
That's a powerful story there, something that made a big influence on you and carries weight there. So I appreciate you sharing that. And Dr. Overschmidt, if you would give us an introduction.
Hi, I'm Dr. Overschmidt. I am the statewide audiology program specialist at CRS. And what that means is I coordinate our audiology program. I make sure that our audiologists have the equipment that they need. I help write policies and procedures, make sure that those are adhered to. I make sure that our hearing aid program is up and running and maintained. And I also work with the Department of Public Health in their Universal Newborn Hearing Screening Initiative to make sure that infants receive their newborn screenings in a timely manner and any diagnostic testing that needs to be done. I am on the board of directors for speech and hearing programs and state health and welfare agencies, also known as dysphagia. It's a very long acronym. I serve as the representative for the American Speech Language Association Audiology Quality Consortium. I do not have as inspiring of a story as Ms. Cleckler as to why I became an audiologist. I was actually in the Navy training on electronics, and I had to be discharged early due to a medical condition. And afterwards, I went through the VA system, and they did some, I just didn't know what I wanted to do. I had always wanted to be in the military since there was a movie back in the 70s, Women at West Point. And ever since I'd watched that movie, I wanted to be in the military. Well, the VA helped me find another career. They did some aptitude testing, and actually the first thing on the list was funeral home director. I think because I have a lot of empathy for people, that just really didn't sound like a good plan. And the next thing on the list was audiologist. And that really combined my empathy for people and the electronic side of things. And it just has been a perfect match. I've been doing this for over 20 years, and it was a perfect match for my personality and my interests.
I always wondered about those tests because in high school, you would take these tests and say, this is what, you have a good probability of being involved in there. And I think mine was like an actor or comedian or something like that.
It was accurate for me. So you never know, Alex, you might have acting.
Maybe one day I'll get now, are you originally from Alabama?
I am not. I am from Missouri.
Very nice. And did you go to Annapolis? You mentioned West Point there.
No. That was just a movie that I saw as a young girl. I was in boot camp in Orlando and then training in Great Lakes, Illinois.
Nice. Now, you both mentioned that you're kind of involved at the policies and procedures level, more managerial. Do you women have an opportunity to still see clients, or do you miss seeing clients on a day-to-day basis?
It's funny, we were just speaking about that before we went on, about how we do miss seeing patients, and we both have opportunities. I can work feeding clinic and cleft palate clinic. In some of our clinics, I can't work our augmentative technology clinic because I'm actually the Medicaid reviewer for all ACDPA. So if I did a clinic, then I would be like, yeah, it's the best report ever. Of course it needs to be approved. No, but Carrie can speak more to it, but I know I certainly missed direct patient care of all ages.
Yeah, same here. I do miss patient care. Fortunately, I am able to be in clinics sometimes in certain areas in this state. If we have sometimes a hospital's newborn screening equipment will malfunction, and we'll need, we'll just have this influx of babies that haven't even had their birthing hospital screening. So our director will allow me to go in and screen those babies in this area. So I do get to see the babies every once in a while. So that keeps me in practice to a certain extent.
Keeps you fresh. Now, do all babies have to be screened? Is that normal for all babies to get audiology screening?
Yes, there's a state mandate for all newborns to have their hearing screened before they leave the hospital.
I didn't know that. I don't have any kids, so I don't have any direct experience there. Not yet. So let's talk a little bit from like a parent's perspective. At a young age, you would know that your child has a little bit of hearing challenges there. I'd like to, Mrs. Cleckler, if you could speak about some age-related difficulties that a child could be experiencing that would warrant some help in the speech-language pathology area.
Well, with speech language pathology, you actually mentioned hearing, which the first thing most speech pathologists would do is we would refer to an audiologist because we would want to make sure that the child could hear and that everything was going okay with their hearing. At all of across the age span, you'll find listings of developmental milestones. And a lot of times, I even did this as a parent, a lot of times parents will see a developmental milestones list and they'll say, my child hasn't done all of that. Or I've done these in this category and I'm behind on this one and I'm ahead on this one, and that's okay. There'll be a link for the CDC's developmental milestone tracker. That's a great app. I even used that. It just gives you a guide. You want your child responding, turning their head to sound when they're a baby, and then looking at you and smiling, babbling, just attending to you when they're infants. And then later you want to see that reciprocal play or them bringing you something. The delays would be I think probably the first thing that I always thought of as a parent or as a clinician was hearing. If you're not responding, if I'm standing behind you and doing that sneaky psst sound or some little sound to try to get their attention, so there's no visual cue and they're still not paying attention, my first thought is always go have their hearing checked. Can they hear me? Because until you get that down, I feel like I don't know where to go without saying hearing is fine. And then I start looking at all of the other things as a parent or as a clinician. So, Carrie, I mean, you may have more thoughts on hearing from the beginning.
So hearing is really the foundation there.
I feel like it is.
Of course I do. So I'm not biased at all. Yeah, a lot of times, you know, in infants, we have a pretty good grasp on that with the newborn hearing screenings. We usually are detecting hearing loss earlier than we used to. A lot of times in older children, parents will say, you know, I think they're just ignoring me. You know, it's a teenager, they have selective hearing, or maybe the teacher thinks the kid is a behavior problem. Sometimes those are because the child just, you know, isn't hearing as well as they should. And it does cause you to be inattentive. If you're not picking up all of the signal, you kind of lose, you know, the conversation and it can look like inattention. So sometimes we'll have parents come in saying, you know, we've had our kid evaluated for attention deficit, that was fine. And now here we are to see if there's a hearing loss. And vice versa. I've actually had children diagnosed with attention deficit disorder. And then we identify a hearing loss. And after the hearing loss is treated, guess what? Those attention problems go away. And of course, you have children that have both attention difficulties and hearing loss. They can coexist.
Now, what would you both say to a parent if they're noticing that their child maybe isn't hitting some milestones at those age-related mountains there? Mrs. Cleckler, if you would kind of lead us there.
My first thought would be go speak to your pediatrician. And often parents will come back and say, but I did, and I didn't get the information that I was looking for. Okay, well, if you've spoken to your pediatrician and you feel like you didn't get as much information, contact early intervention. Call your friend down the street if you've got one that's a speech therapist or an audiologist. It's amazing how many folks from work will say, hey, I know that my child's not enrolled, but I have this, my kid is 7 and this is what they're doing. Is this okay? You know, and I'll pull together the developmental norms. It's okay that they're 5 years old and their S isn't where it should be. That's not developmentally appropriate. It's really okay. But here are some things that you can do, those sort of things. So I would say definitely early intervention would be the next place that I would reach out to if I didn't feel like I was, as a parent, getting the support from a pediatrician just for some information. And I'm always a very big proponent of saying, call your local university program that has a speech and hearing center, because not only do those students need the hours, they have top of the line equipment, PhD level professors that are running those programs. I mean, if you want your child looked at, that's a great place to go. A lot of times there's a waiting list, but there's generally a very, very minimal cost. And so I also refer anybody to a program. So for example, AUM, University of Montevallo, Sanford University, USA, Auburn, A&M. I'm going to be missing someone, and I apologize.
We can always put it in chat later.
But call up the speech and hearing centers and see if you can get in and see them and just discuss you're going to have really good information coming from folks with a really broad knowledge base there.
Dr. Overschmidt, is there anything you'd like to add to that?
Yes, you know, I agree with Ms. Cleckler, and I absolutely would talk to the pediatrician. In some areas across the state, they may, you know, a parent may not have options for university settings or may not even know anyone in the field. So I would say advocate for yourself and your child. Talk to that pediatrician again, be the squeaky wheel if you have to. The Joint Committee on Infant Hearing, that is the #1 risk factor for hearing loss, is parental concern. If you're concerned about it, advocate and get somewhere to get tested. We do hearing testing in 13 locations across the state at CRS. You don't have to have a diagnosis of hearing loss to be eligible for services or for screening and testing. If hearing loss is identified, then we have some things in place for eligibility. But if you're between the ages of birth and 21, we can test your hearing at CRS.
Now, we mentioned kind of the hearing loss and some of the tests early, right after birth. Is there another milestone that really sticks out to either one of you as someone is starting to grow there, 5, maybe 10, that would be another kind of challenge there, or another milestone that really gains a lot of attention at a different age?
You certainly want your toddlers, from a year up, starting to try to use speech to communicate, along with not just with, I'm going to grab your hand and take you somewhere, I'm going to bring you something. It's not that that's not appropriate, but as you're modeling words to them, if their hearing is intact, you want to see that through the toddler years, those toddlers are putting one word together, even if it doesn't have to be a perfect sounding word. That's okay. But they're using that same word for whatever object it is, whatever action it is that they're wanting. And then you want to see them start adding 2 and 3 words together. And those are things that I even feel that sometimes personality plays a role into. You may have a child that's not quite as talkative, or you may have that younger child who has an older sibling that speaks for them all of the time. And I've seen that. And the child didn't have a reason to speak because the older sibling talked for them all of the time. And so a lot of times that will trigger some fear and concern, and rightfully so. Why is my child not speaking? I know he understands what I'm saying, and I know he can follow directions, but he's not talking as much as I would like him to at this point. And then you find out, well, he's got a big sister who's really, really chatty. And she goes ahead and interprets everything before he even has a chance to speak. One of the things I'd like to reiterate that Carrie just said is about mom be the squeaky wheel. Yeah, definitely. Moms and dads, don't let anybody tell you that you don't know your child better than anybody else, because it doesn't matter how many degrees somebody has or how many letters behind their name. That's your baby, that's your child at any age, and you know your child better than anybody. So yes, I wanted to come back to that. Make sure you keep coming back to whomever you need to, as many times as you need to go, but I really feel like something's not right, and here's why. Because you do know them better. And no matter what expert you're talking to or what person who gets paid to do that job, a lot of it's going to be generalization. They don't know your child on a personal level like you do. You want to see children by around the age of 2 copying other people, playing pretend. And as they grow up through their toddler and kindergarten years, there's a lot of imagination that you could see. Getting excited when they're around other children, pointing to things. And that's not to say that communication is all about naming and pointing, because it's not. But they get excited that they know what this is, and they point to it and name it. And that's usually, especially if it's been modeled for them.
I have a question.
I know what you were looking for.
That's perfect, because this is all unknown to me. I have a question. I have a family member that has an intellectual disability, and she's seen doctors over her life. She's 57 years old, and they say that she functions at about a 3-year-old level. And there are things when I'm with her that I think she does that maybe a 7-year-old would do, but I think she's far beyond that, what the doctors give her credit for. Do you know at what age kind of humor plays a role? So we'll be driving sometimes, and she will pull the car from drive into neutral, and we'll be doing 70 down the highway, and I'll be going, what the heck is going on? Freaking out. She'll be looking out the window, just cracking up. like she's playing a prank on me. She's also locked me out of her house before and has laughed when I had to climb through the window. So where do you see kind of, at what age would you think that would kind of take place in that development? You think at 3 years old that they kind of get that joking prankster?
Oh yeah, and and you hit 4, 5, and 6, and they're telling the most ridiculously lame jokes that aren't jokes and laughing their head, and you just have to play along and laugh because they don't get the punchline of it yet. But definitely that pranking folks, and you know, standardized test or saying somebody functions at a certain level, and we're just going to blanket this entire human and say, oh, they only function at the level of the 3-year-old. Really? I think people are more complex than that. You're more complex than just you only function like a 3-year-old. So yes, humor is a way of communicating and pranking and playing jokes, and to put an age on that or to say you can only function this way and you shouldn't be left alone. But you might want to get into maybe you can't live independently because of problem solving is not developed to the level that it should be, and now you're at a safety risk. But I mean, my brother was labeled at a somewhere between a 3 to 5-year-old level, and there were some things that seemed quite appropriate, but other things, no. He had a wicked sense of humor and a great memory.
Yeah.
So I usually don't like it when people try to just blanket an age on someone and say that's the only way they can function. We're all multifaceted. We shouldn't take that away from anyone else.
Mhm. I agree. I would like to acknowledge chat really quick. Holly Cawthorn says, hey, Holly, I love Holly. She's with ACDD right now, and she's been great for us going back and forth. She says, thank you for being here, Sonia. Alex, Sonia and I used to work together. I have to go get to another meeting, but can't wait to watch this after I'm done. Andrea Kreiner Carroll says, hey, Sonia and Carrie, great job, ladies. Sarah Williams says, hey, Sonia and Carrie.
I mean, what love.
Yeah.
Awesome. Thank you.
In the research for today, I came across a couple hot topics about brain development and how receiving services in early intervention can help that child continue to develop. If you would talk a little bit about, just that, how receiving services at a young age can help that child continue to develop intellectually through those formative years. Dr. Overschmidt, would you like to take this one?
Sure. So brain development plays a critical role. And we always say that we hear with our ears. I mean, people think that you hear with your ears, but really the ears are there to collect and transmit information to the brain. And we really hear with our brains. And so when we talk about hearing loss, if we diagnose a baby with hearing loss, they are already way behind. In utero, at 20 weeks, the auditory system is fully developed. So they're already 20 weeks behind when they're born. And now they may not be diagnosed until 3 or 4 months of age, and then maybe hearing aids by 6 months of age. And that's usually the best case scenario. So it is a developmental emergency, because what happens when you do not have sound input to the brain, think of it like a tree. During the first 3 years of life, the brain cells are blooming like a tree. They're growing all over the place. And there's wiring that happens with all of these neurons and connections to the neurons. And so while this is blooming, if you do not have sound input in the areas of the brain that are pre-wired for the sound and speech and language to occur, just like a gardener that may prune branches that aren't needed or maybe aren't being used, the brain starts to prune those connections. And so we call it synaptic pruning. And so when you don't have that auditory input to those areas, then other senses that may be normal, like vision, can actually compete for that real estate and take over the auditory area. What that means is, if you wait past 3.5 years or so, the space for auditory development really has been taken over, and it's very difficult, if not impossible, to regain those connections and learn to hear normally or acquire normal speech and language.
The brain is an amazing organ tool to be able to do that. Now, you mentioned the cutoff there at about 3.5. So when you talk about the pruning there, the synaptic pruning, what if someone was, say, 5 and had been deaf or hard of hearing up until age 5, and then at that point it changes and they have vision loss and they start to get their hearing back? Can the brain change that pruning?
So if someone is born with a severe to profound hearing loss and they do not receive any intervention, is that what you're saying? They haven't had any. So if they haven't had any intervention, any sound input to the auditory center, hopefully they've had intervention. And not all families, there are deaf families who choose, who actually use American Sign Language, and they don't wish for their child to use listening and spoken language. So for those families, as long as that child's in a visual rich environment with a lot of visual language, their language will develop normally. But if you have a child who's 5, who does not get any intervention, has normal vision, and then you decide to intervene at 5, the prognosis is very, very poor for normal speech and language development.
Mm-hmm. Mrs. Cleckler, is there anything that jumps out to you about brain development and receiving services at a young age?
Yes, certainly. The earlier, the better. And that's not just from people outside of the home. That's definitely from whoever is in the home caring for that child is making a difference by what they're doing around the child. I'm a huge proponent of reading to your baby every day. And so you think, why am I reading to this infant right here? Well, just read your novel out loud, because they need to hear those words, because they need to hear the cadence of your voice, because they need to hear appropriate grammar. You are firing those neurons in the brain and and connecting those pathways instead of just being quiet to that child. And TV does not replace humans speaking to a child. And the American Academy of Pediatrics even, and this is not going to be a popular thing to say, but it's true. There's so much data out there on it, and there will be a couple of links at the end. No screens before the age of 2. Can I say that my children never looked at a screen before the age of 2? No, I can't say that. But children over the age of 2, even limiting screens to 1 to 2 hours a day max. And I know you're going, wait, we're in a virtual world now, in a COVID world, and there's distance learning. What do we do? And this is including all screens, TVs, phones, video games. But there is a direct amount of, there's a correlation between when screen time goes up, developmentally children suffer, their language suffers, their emotional ability to regulate suffers, all of those things. Think about it this way. If you had a baby who's watching, or a young toddler watching a ball roll to them on the screen, well, that's great, but it's not the same thing as an actual round sphere rolling toward them that they can move toward and grab and feel. It's a completely different thing. They need that real ball before that representation of that ball actually has any real meaning. And so, yes, starting early with giving them real experiences, bombarding them with language, talking to them about, narrate everything that you do. And if that were in sign, fine, however, but just give them that rich language environment of, we're at the grocery store and you're talking to your little baby in the car seat, sitting right there in the grocery store, and telling them that that's an orange, and that orange is round, and it's a fruit, and it smells good. And what else is round? Oh, look, this apple's round, this apple's green, and this apple's red. And you think, some folks are very talkative naturally, and other people aren't. Believe it or not, I'm actually quiet by nature. So for me, I had to think about, I need to be talking about these things with my kiddos because they need to hear my voice. And so mamas and daddies out there, and grandmamas and aunts and anybody that's in the house, Talk to your kids about whatever you're doing all the time. It, you don't have to wait until they can talk back or until they're moving. Talk to them as babies. That's very, very important for their development. That's why early intervention is so important.
I have a few follow-up questions there. What are your thoughts on baby talk?
I'm not a proponent of it. Most speech therapists you will find are not. I don't think that it is the end of the world if, if you have a grandmother who is going to do baby talk and they refuse to do nothing else. I don't think that that child's development is going to be stumped and you need to leave that grandmother out of the baby's life. So don't think I'm taking it to that extreme. But I think they need to hear appropriate speech, good grammar, good articulation, your pronunciation of words, because that's what's helping them develop. So if somebody in the family is saying, do you want some din din, and they mean dinner, then you can tie the two together and say, did you, Nana asked if you wanted some din din, it's time for dinner, or whatever you call it. But just tying it together to give that real meaning, but then also giving the real word.
And then you mentioned a 2-hour limit there. You said where it gives negative feedback on screen time. Is that the limit for children, or really for anybody throughout the day?
The American Academy of Pediatrics, that's the recommendations right now. So there'll be a link that I sent to you that has a write-up on that, which if you're under age 2, they recommend no screen time, and children over the age of 2, 1 to 2 hours a day.
Yeah.
So
I feel like I need to implement that.
I think we all need to.
I think I look at a screen probably 8 hours a day.
Right. Especially now.
Yeah. Our meetings are on Zoom. A lot of my work is on the computer, and then I have my phone in my pocket whenever I get bored. I'll be
Right.
at the doctor's office waiting in the doctor's room yesterday for a half hour, and I was on my phone the entire time.
Take a book.
I need to. That reminds me of a story. When I was growing up, I had a friend in church. I didn't really think much of it, but he had some speech difficulties, and we went on a trip to help build some housing, stuff like that. And it was an overnight trip. And he actually would put on headphones when he slept. And I don't know what was on the tape. It was an old cassette tape at that time. I don't know if it was like a book on tape, but have you heard things like that where somebody will sleep with audio going on in the background?
It's probably a personal preference. 2 of my 4 kids love to have a TV running in the background just for a background noise, and they say it's so they can't hear, maybe the tree branch scratching against the window or something like that. So it basically serves as a white noise. I want it completely silent.
Something that maybe a pediatrician or somebody suggested at a young age for them. Have you ever heard of anything like that, Dr. Overschmidt?
Well, we do have people who suffer from ear ringing or tinnitus, and sometimes they will sleep with white noise, like Sonia mentioned, or a fan on. Tinnitus can be debilitating for some people, and it's kind of like it's usually more difficult for people when it's really quiet. So if you think about going into a room that's lit and you have a TV screen in the room, and you walk into the room, you don't really notice that TV screen right away. I mean, you may see other things like a bookshelf or chairs, but as soon as you turn that light off and you take that visual stimulus away, what pops out at you? The TV screen is going to pop out at you if it's on. So tinnitus is the same way. During the day when you're around people and you're talking and communicating, or you have, other things happening around you, not so much this year with COVID, but, we live in a pretty noisy environment. And so when you get home, you're in bed, now everything's quiet. For some people, a lot of times it can be linked to hearing loss. The auditory system is kind of searching for stimulus. And so there are a lot of different things that can cause the ringing in the ears. But that certainly is a time when people can notice it more often.
So it wouldn't really be for trying to have better speech then, is falling asleep with some type of headphone or guide there. I always thought he was wearing the headphones so that it would help his speech, but that's not really the case.
Well, it could be. I actually used to to sleep with I'll age myself, a Walkman with headphones on, and I'd fall asleep to music. And I think some people do like that, but for other people, you know, it can be um, somewhat of a treatment for ringing in the ears.
I have audio going on all day for myself. Whenever I'm working, I have music on in the background. And ever since ninth grade, I've fallen asleep with some type of audio in the background, whether that's radio or a TV on and very dim. But I have to have that for myself. It helps me concentrate for whatever reason.
I mean, it's self-soothing for you, so there's nothing wrong with that if it works.
Yeah. I'd like to talk a little bit about kind of the first visits and what children and families can expect on their first visit to see a speech language pathologist. And Mrs. Cleckler, if you would kind of take the lead there.
Okay, so it's according to where you're going for your first visit, really. Are we coming to CRS for a first? Honestly, if you're coming to CRS for a first visit, more than likely you've been to someone else, another speech language pathologist, and you've been referred here in general. So a first visit could definitely happen with an audiologist here at CRS. I think a lot of our clients are already accustomed to everything that you do with speech language pathology because they've had it in early intervention, they've had it in the school system, maybe outpatient. What we don't do that you would see in those other realms is we're not going to sit down with a lot of diagnostic evaluation tools with the point to this and touch that, simply because standardized tests aren't standardized on most of our clients that we see. They're a lot more involved than the typical population that the tests are normed on. And so in school, they may sit down and try to have them, and it's because they have to have some sort of data. I'm not knocking school at all, but they may have to try to get a test done to see if they qualify. And for us, you're coming in, and if your child is nonverbal, they're nonverbal. So then we're looking at them in a play situation, very much like an early intervention model, except it may not be in their natural environment. But in that, we're looking at how do they interact with their family members? How do they interact with us? How do they request something? Is it just by an eye gaze, glancing over, grunting, reaching over? Can they show negation? So we're going to look like we're just playing with or hanging out with your child if you've brought them to augmentative communication therapy clinic. If they've come to feeding clinic, the speech therapist and OT also very much may look like they're playing with the child with food, because we're looking just to try to establish rapport. And then how do they interact? And we don't want to scare them off, certainly with feeding clinic for a child who has sensory or food or smell aversions, and say, here, eat this. That's not going to work. So it's a lot of playing with the food. Will they even let them, can we get it near them? Or we may be eating the food or rubbing it on our hands and things like that. So parents will probably look at speech pathology in the context of CRS and our services in our clinics and say, well, you're just playing with my kid and hanging out with them for about an hour. But we're getting a lot of good information from that.
I've heard somebody say that like 80% of what somebody's saying isn't actually verbal. It's a lot of posture, eye contact, and how you're interacting with your environment. You can pick up a lot on that. Even if you can't hear what somebody's having a conversation about, you can see the conversation from a distance. Would you agree with that?
Yes.
A lot of communication there. Dr. Overschmidt, if you would prep somebody for maybe their first visit to see a auditory or audiology specialist.
Sure. So for the CRS audiology program, some of our clients come to us with a diagnosis already, and the family's pursuing hearing aids. We are one of the only Medicaid providers for hearing aids in the state of Alabama. So it's very likely they've been diagnosed somewhere else and they're coming to us for hearing aids. These clients will see the CRS audiologist in our hearing aid clinic. And at that time, the audiologist will reconfirm the hearing loss and then talk about hearing aids and look at different options with the family. and the client to see, what is the best option. We'll talk to them about educational needs, in terms of what type of technology may they need, so that they're on equal footing with their normal hearing peers. Medical clearance is recommended by an ear, nose, and throat physician. So that can happen if the child is established with an ENT, or they can come to a CRS hearing clinic where they'll see an ENT physician at that time. We also have social workers and nurses that work in that clinic. We can, over 50% of all hearing loss that's identified at birth is due to genetic cause. So we can order specialized testing for genetics. Sometimes CT scans or other tests can be recommended so we can try to find out the cause of the hearing loss. Sometimes that definitely helps with our treatment plan. Other children actually come to us. Like I said earlier, we do a lot of newborn hearing screenings. People are familiar with the traditional hearing test where we put the headphones over the ears and you raise your hand when you hear a tone. But audiology has advanced a lot over the last 20 years, and we have some incredible ways to test. To me, the fact that we can test a newborn is a testament to how much our technology has changed. At CRS 2019 to 2020, we saw about 900 infants each year for rescreening. Those are babies that did not pass in the hospital and came to one of our sites across the state for a rescreen. So those babies will be rescreened at CRS, and if they don't pass that screening, then we do some diagnostic testing. And that test is called an auditory brainstem response test. It can sound kind of scary because we're talking about the brainstem, but it's a very routine and safe and non-invasive procedure. Basically, the audiologist puts some really soft, small earphones in the baby's ear. And then we have some very soft stickers we place around the ear and on the forehead. And from that, we measure brain waves, and that can tell us how the hearing nerve is working.
Measuring brain waves, that's amazing.
Yes, yeah, we can estimate hearing based on those brain waves.
And when you're kind of going through this, I can see how maybe children or parents would be a little bit nervous to go to these meetings. There's a lot of pressure, is it going to be a good result of the test or what that looks like? But what would you say to parents that are maybe in that space?
I think Carrie hit the nail on the head when she said at our clinics, we have social workers, nurses, that they both serve in the capacity of care coordinators. We have parent consultants. We have parents who have lived that.
We can hear you. You're kind of in and out there, but we can't see you quite yet.
Alex, I'm sorry. My connection is. Can you hear me?
Yep, we can hear you. Can you hear us? And what we can do is I can send you another link and then we can rejoin. Oh, there you are. I can see you now.
Sorry about that.
No worries.
What happened?
So Mrs. Cleckler, you were speaking about kind of the social workers that are on campus and can kind of hold the hand for the families.
Nurses and social workers, like Carrie mentioned, are care coordinators. There are lifelines for helping the parents navigate. We have other therapists. We have parent consultants who are present, who are actually parents of a child or a youth with special health care needs, who can come in and share their story that they've walked through. There are going to be so many people, but not in a, we're all coming at you to test you and we're going to make a decision today. Every time there may not be a decision. With hearing, there may be, because they have those direct testing results. And I'll let Carrie comment on that. But with an augmentative communication device, we may need to look several times and have several visits and maybe go out to the school system or go to the home and look and see what works best. And sometimes, kids they've got white coat syndrome. They've been to so many doctors and seen so many folks. We're scary too. We try not to be, So we'll go see them in the home or go see them in the school or somewhere that they're more comfortable. And a lot of times you'll get a much better result. And so, certainly for the speech pathology aspect, I don't want parents thinking it's a one and done. We're coming to see you one time and you're going to fix it and you're going to know exactly what my child needs. We're not, because your child's more complex than that. And we want to make sure we do a really, really good job. But that's going to be with a lot of folks supporting you and your child, not just, here you go, let's write a prescription and file this paperwork and try to get something for you. We want to make sure that what you get is the right thing and the appropriate thing.
I think having that family peer advocate is really beneficial. As somebody that's already been through the process and can relate to you on a personal basis there, would relieve a lot of my nerves there. Dr. Overschmidt, if you could comment a little bit how it might differ there when you come in for an audiology test and you do get the results that same day.
Sure. Well, the first thing families need to know is, for the audiologist, giving a diagnosis of hearing loss is not easy for us. It is, we don't like to give that diagnosis necessarily, but we know that the prognosis can be very great with great early intervention. We are going to be here to support them the entire journey. We are here, and we have families sometimes that can't even get to the point of accepting the hearing loss because maybe they're worried about losing their electricity because they can't pay the light bill, or they're in the middle of a move. And so we have those care coordinators that can help the families find the resources they need to solve any other things that may be going on in their lives that really need to be taken care of before they can worry about, I have a child who has hearing loss. One thing that we also have is in our electronic health records, when the audiologist, after a diagnostic test, we enter those results into our electronic health record. And anytime that hearing loss is a diagnosis, we have a parent consultant who is for our deaf and hard of hearing population. She gets an email with the demographic information of those families, and she will reach out to them. Currently, our CRS parent consultant for the deaf and hard of hearing population is Jessica Havard, and she has a daughter who is hard of hearing, who actually just received a cochlear implant not too long ago. So she's been through that journey. I can be with the family on the diagnostic side of things as that part of journey, but having that parent that's been through it, my perspective is very different from a professional that doesn't have a child with hearing loss than the actual parent. And so it does help. And Sonia spoke to this earlier, that the families are the experts in their children. I may be the hearing expert, but I may see that child for an hour. And the mom or the dad or the grandparent, the guardian, they're with that child all the time. And we really rely on the input very much in audiology. We can do some tests in the booth to determine how well the hearing aids are working, and some verifications with some special equipment. But we really need that parent input to tell us, how are they responding to their name? Has the teacher noticed a difference? Are there certain sounds that they're not responsive to more than others? Are they tolerating wearing the hearing aids, or are they pulling them off? Or, sometimes you have a child that wears the hearing aids fine, and then all of a sudden they just stop wearing them. And sometimes it means there's an issue with the hearing aid. So the parent input is so important, and we rely on it, and we really want to go through that journey with them at CRS.
I like how you hit on the parent input there. And you mentioned cases where maybe somebody they're worried about the electricity going off. So I love that CRS takes a holistic view there to really try and help that family to support that child. Because I feel like a lot of, whether it's speech language or audiology, they may spend an hour in the office once a week, but 24 hours at home with their parents or whoever's right around them. So I imagine a lot of it is training the families as well, to continue this outside of the doctor's room, I'll say. What are some examples of common goals that someone could kind of rely on throughout the process of going to speech language pathology or audiology, or no, we'll focus on speech language pathology. But what are some common goals that you would work on in early intervention or after?
If it's communication, and we also deal with swallowing and cognition and fluency and voice, so there are a lot of different things that speech pathologists do work with. I'm thinking from a CRS perspective and really focusing on communication. We want everybody to be able to functionally communicate their wants and their needs. Not just name something, not just be able to point to something when they're asked. That's not functional communication. You know, if somebody keeps giving you chocolate milk and all you want is apple juice, then we want you to be able to communicate that in whatever way possible. If you don't want something, if you're tired of something, an appropriate way to negate and refuse is really, you know, you're going to get negation and refusal, but it may not be verbally or with a picture symbol or with the appropriate thing. It may be that if I don't want to do what you're doing, I may hit you. I may scream. I may throw myself into the floor. That's all communication. I don't want to do what you're trying to make me do. So then replacing that behavior, which is communicative, with a more appropriate form of communication. And then also just having a choice of being able to say what you do want to do, or that something feels bad, or that you like something and you're sad that it went away. That's really just the basis to me of functional communication. And that's what we want all of our folks to do, whether it's with sign language or pictures or a device that speaks, or with their mouth or gestures, or with a combination of all of it.
When you
whatever they want, they need to be able to share with other people.
I feel like everybody should have to go through that. I think some people get older and never go through that, and they have not very great communication skills. So it should be a recommendation that everybody go through that. I didn't realize that eating and food was such a big thing in speech language pathology.
Dysphagia is a disorder of swallowing, and it may be because your mouth, your muscles, and the muscles in your throat, they don't work together, or they may not work well. One side may be weaker than the other. There may be sensory issues where things feel funny, and so we just don't want to deal with that. Timing issues on how quickly the muscles fire and actually activate, but swallowing is actually very complex. And other than just making sure that you have appropriate nutrition and hydration from swallowing, and we work with registered dietitians, nutritionists on that. Our RDNs are great with the nutrition. We want to make sure that somebody doesn't choke to death, because we don't want their open airway to have a piece of food blocking it. We don't want something to fall down into their lungs and then them develop a pneumonia from the bacteria that is in whatever they aspirated. You see a lot of children with feeding tubes. You can have reverse aspiration where they reflux up the esophagus and then it spills over into the airway. And so even with our children who don't have anything by mouth, some of them could be at risk, and it may just be looking at positioning or speaking with a GI specialist about managing their reflux. You also see that with adults after a stroke or a brain injury or ALS. You'll see swallowing issues. So we do more than speech in speech language pathology. A lot of folks just go, hey, speech teacher, but it's a little bit broader than that. Just like audiology, if you could see the vast equipment that they work, that I will never touch because it is very technological
and expensive.
I never thought about the eating and the speech before. It's so closely linked. My family member, as I mentioned, she's 57. She is nonverbal, and she communicates, through kind of grunts, I'll say, and pointing. And we have a tech talk that she uses. Does not like her tech talk, but she has her own communication style. But she does have trouble. She doesn't chew. She kind of just swallows. So we have to make sure to cut up her food pretty fine. And if she eats too much, she throws up. And so she's on some acid reflux medication, stuff like that. But I never linked the two so closely before until you kind of went through that. That's pretty cool.
All of those mouth muscles used for speaking are used for swallowing. I mean, same muscles, same structures, just for different things. And so we have to learn about all of that in school and apply them to either speech or swallowing.
Now, you've mentioned that that could happen after like a stroke. Now, you both are at CRS, but do you do any work with older clients, maybe as they're starting to have hearing loss or after a stroke? Have they gotten older?
We can serve people above the age of 21 if they are enrolled in state of Alabama independent living, SAIL, or vocational rehab from the speech pathology side, because we may have someone who has ALS or someone who has something acquired like a stroke or a brain injury and they're over the age of 21. But if they're enrolled in that program, then we could look at them from the augmentative communication technology clinic. And so we can recommend a device to assist them with communicating. Also, our clients do grow up and they age out. And so if they qualify for SAIL or VR services, we can continue to follow them that way. But that's specifically through the augmentative communication technology clinic. And then I'll defer to Carrie for audiology.
So the audiology services are from birth to 21 years of age. After the age of 21, a lot of our clients, like Sonia said, they grow up. Many of them qualify for vocational rehabilitation services. And so they have audiologists at Voc Rehab that can take over their cases after that. And usually we start that process well before they're 21. We work with VR in T transition clinics and things like that.
Yeah, to make it pretty seamless for them. Now, what are some more specific learning exercises that specialists do with children, Mrs. Cleckler? If you would kind of introduce us to that.
So I love that you're using the term specialist because I'd like to think that I am a specialist because that's what I get paid to do. But I really feel like our parents and caregivers and grandmothers and everybody at home, you're the specialist. So don't forget that you are the specialist. You know how to play with your kiddos. What did you do if you're a grandmother out there? You were playing patty cake and singing nursery rhymes and singing songs. Well, all of those things that our grandmothers and mothers did with us when we were growing up. There's so much evidence out there now to support that helps with language development and social emotional development and literacy. And so our grandmas and great grandmothers who may have just been telling us nursery rhymes and we thought they were doing that to entertain us, they were the specialists all along, doing the things that we now have data on that shows that's what you should be doing. I think communication, constant communication, like I mentioned before, always talking to your child and play, interactive play. It kind of amazes me that I think it's the CDC, Carrie, maybe Asha, they have signs out there for adults to tell them to put down their phone at the table and speak to their children. And I'm thinking, even if I wanted to look at my phone, I couldn't because my children will be sitting on top of me in my lap and I'm going to give them my full attention. But make sure that you're interacting with your children, because if your child is in therapy, yes, you're going to need some insight from that therapist, from that audiologist, from whomever you're seeing, because they're going to have some tricks up their sleeve. They're going to have, they should have knowledge of the newest things that are out there. And they're going to be able to look at your child and say, you know what, try this, but then go home and try it and continue to try it. There's no quick fix to anything. Language development is a process. And so you're just supporting it in any way that you can by interactive play, reading all of the time, talking all of the time, showing them about cause and effect, imaginative play, role play, all of those things that you think of, oh, well, they do that in preschool. Do it at home too. There's so much to be learned. There's so much that our children gain from us giving them that kind of attention and that kind of play that you can't just get 30 minutes once a week in a therapy session or an hour once a week in a therapy session. I just really feel strongly about that therapy is really at home. Yes, get the information from your therapist, but you're the teacher at home.
Do those tea parties.
Yes, definitely.
I saw a video the other day where this dad and daughter, and she was doing some type of dance for a dance recital, and he was going through it with her the entire way, the kind of stuff, and it was adorable. It was really cute. So engaging in ways like that. Speaking of the newest things out there, let's talk a little bit about assistive tech, augmented communication tech. What exactly is that?
So augmentative and alternative communication is known as AAC, and augmenting something is just in addition to what you do. Alternative is completely different from your speech. So just to give you the two words, a simple version of the two words. All of us use alternative and augmented communication. You see my hands down at the bottom of the screen. We have facial expressions. If you text anybody, you've probably used a meme or a GIF, a little emoji. That's all AAC. We use that. When you were in school, you wrote a note, and you folded it up and drew little pictures and flicked it to somebody. Same thing. You weren't looking at them in the face, speaking verbally to them. So that is, and we're all using AAC. The newest and greatest technology is always going to be old technology by the end of the day. It is for your phone. It is for everything. Technology is moving so rapidly. I think my biggest encouragement for parents when they think AAC, especially a high-tech device, may be the route to go, and it very well may be. One, please don't let anybody tell you that that's going to delay your speech and language, because it will not delay your child's speech and language. And there is plenty of evidence out there. There's going to be a link for the AAC myths, but it actually is supportive of the language. You don't want somebody with a broken leg walking without crutches. So think of it that way. It's no different than that. It is a support, and a lot of times it can encourage more language and more verbal output. But that technology is going to change all of the time. So I would encourage folks to not just look at one manufacturer. Whoever is presenting to you, what's their stake in it? Am I a sales rep? There's nothing wrong with sales reps. I love all of our sales reps. They're great. But am I getting a commission for recommending this device? Obviously, if I worked for a device manufacturer, I would probably think that was the best device manufacturer ever. So you're going to get that side of it. Everybody thinks differently, everybody learns differently, and everybody's language is different, regardless of the presence of a disability or not. And so you could line all of us up and we would all be different device users, because our brains work differently and we interpret language differently and we think differently. And so that's okay. So my advice to parents would be, look at all of them. Try to have somebody who's going to show you a broad variety of things. And that device in the end is still not a silver bullet. You don't put it in front of them and you just magically start talking. When people get prosthetic legs, generally, you don't see somebody put on a leg and walk out and go run a marathon. They need physical therapy to teach them how to walk with that. You're going to need speech therapy to teach them just how to navigate the device, because it's something different. And like you said about your family member, with the grunting or the vocalizations, you know what? That works, and that's easier. And we all take the path of least resistance. Another thing is, you may have a $10,000 to $18,000 device that's speaking for you, and that's superb. What do you do when you're in the pool or in the bathtub? You can't use it all of the time. So it's always going to be okay to have some sort of low tech or mid tech. Again, we all use AAC. Now, I'll cover up the device manufacturer on this. Can y'all see that?
Yeah.
It's a slap bracelet. It can go on a wheelchair, it can go on a walker, it can go on you, and it has fun little words like savage and slay and mic drop on here. That's communication too, using whatever words are the fun words of the day. These words will not be words that are super cool that all the kids want to use next year. Just like the technology will be outdated. So everything's going to keep evolving. So just try to keep an open mind of what's out there and what does my child seem to use the best or understand the best. I think would be my best advice for technology.
I love that bracelet. I think I'm going to try one of those for my family member, my aunt, because she will point at pictures on her Tech Talk, like if she wants to read or if she has to go to the bathroom. But the Tech Talk is probably this big, and it's tough to take into the community and have sit on her lap, or she won't wear it around her as like a lanyard. So I think I'm going to test one of those out and see if she'll wear a wrist thing and see if she'll point at it if she wants to go to the bathroom when she's in the community. I love that.
You need to get with me afterwards. We've got all kinds of fun, kind of low tech things to use and wearable communication.
Yeah, that's pretty cool. Dr. Overschmidt, is there anything that really comes to mind for assistive tech in your field?
There is. So we have, as Sonia was mentioning, the parents are so integral in therapy for children. And if you mentioned you don't have children, Alex, but if there are any parents on the line, if you've ever had your toddler or school-age child say a cuss word, they probably learned that through something we call incidental learning. Like kids are always learning. Even if you're in another room and you don't think they're part of the conversation, they are picking up on everything. And so one thing we have for infants or even older children is something called a partner mic. And I don't know if you can see that, but it's just a little device that clips on the shirt. And so the parent can walk around with this microphone and wirelessly, so I have some hearing aids here. This is a larger hearing aid, or we have some smaller hearing aids. So the infant or child is wearing a hearing aid. And, let's say the mom puts the baby in the playpen and she's in the kitchen cutting up vegetables, talking to her husband. That sounds kind of sexist. Maybe the man's chopping the vegetables, whatever. They're cooking dinner and they're having a conversation. Well, the baby can actually be listening to all of that auditory input of the parents. We use them for older children in school, so that the teacher's voice goes directly to that child's hearing aid, and it's amplified based on their hearing loss. It reduces some background noise. It's really remarkable technology. We also have devices that can plug into the television. Some of our clients are gamers, and so we can have the game streaming to their hearing aids through TV links and other devices that can plug into computers, televisions. And that's all.
I have a question about that microphone. I live with my grandmother, and she is about to be 90 years old. That's the whole reason I moved to Alabama, is to help with family, my aunt and my grandparents. But I hear the word "what" probably 50 times a day. Drives me nuts. But I've never used a microphone like that. Now she has hearing aids, so I can go myself and get a microphone like that, and no matter where I am, I can have good communication with her.
Yeah, depending on the type of hearing aids she has, probably if she has gotten hearing aids in the last 3 to 5 years, they're very likely Bluetooth compatible. Yeah. And it could be an accessory that may be able to be added on. Again, it's going to depend on the type and brand of hearing aids she has.
You both are giving me great ideas for tools that I'm going to introduce in my family.
There's also some technology. It's called If This Then That, where you could actually, when her batteries in her, if she has the technology, when the batteries in her hearing aids, and this works for parents too, when the batteries are going low, you can receive a text message that tells you, hey, the batteries are going low. And so to change the batteries.
I'm gonna have to go through some of these. I got a lot of research to do after we end this broadcast. I would like to talk a little bit about the telehealth and distance services for children in rural areas, and especially during the pandemic. I imagine that not a lot of people were coming into the offices. What does that look like for you guys individually, and how CRS serves through telehealth? Mrs. Cleckler.
Um, Actually, a silver lining of the COVID pandemic was that it really pushed telehealth forward. We've been needing it for a while, and I don't say we just mean CRS. I mean, therapy as a whole has needed this as a modality that you could bill for to be able to serve people. I think on the positive side, it's been reimbursable. Medicaid and other payer sources are looking at making it permanent, what codes they will pay for, and making that reimbursable. I don't think it's ever going to fully replace human interaction, direct face-to-face contact. That's not ideal. But when you're having a really stormy day and you're trying to load a child in a wheelchair up into a van with your other kids and all of their bags and all of their equipment, if you could do that visit by telehealth, that would prevent you from missing a visit. If the caregiver or one of the siblings is really ill, the child that needed the therapy could still get the therapy via telehealth and not have to skip that visit. One of the things when we started working really quickly to try to get telehealth services where we could not miss provision of services for our kids, that we saw were just instances, just real life instances like that. Sometimes, transportation is really difficult to arrange, and that's a means, or mother is medically compromised and feels safer doing it at home. So there are a lot of benefits to that. I'd say a negative from that is not all rural areas are cell phone and internet equipped. I actually live 2 miles outside of the city limits. I have an almost non-existent cell signal, and my satellite Wi-Fi does not work well enough to stream. And so during the shutdown, I drove 2 miles into town to my mom's house, and she had all of that. And we were thankfully able to do all the things via telemeans, telework, teleschool, whatever we had to do. And she even had some tele-doctor's appointments, and she didn't have a smartphone at the time. We just talked her into that. She's still not happy about it, but being able to go to that, and she got through with her doctor's appointment. She said, this was great. I didn't have to get ready and drive to Birmingham and then sit there and wait in a waiting room. They called me when they were ready to see me, and you held the phone for me, and I was able to have this. And so I think the convenience of it is a beautiful thing. It's not going to replace everything. It's not going to work for everybody, but we were able to deliver augmentative communication devices with a rep showing up at the door and the speech therapist talking to them on the phone and walking them through, here's how you set up this device that you haven't laid hands on, and still being able to provide that support. I also love the idea of group therapy for speech therapy. We have group therapy. We don't do therapy services, we do diagnostic, but as a therapist, thinking of group therapy with a bunch of device users. And so since you're not going to find device users in a high concentration in one area, looking at telegroup therapy and hitting different people all over the state, how awesome would that be for your child to be using a device and say, well, I'm not the only one. Look at this guy rocking out this device, or this young lady using this, or she's using her eyes, or he's using his toe. I mean, it would be a beautiful way to share different experiences and include folks who may feel excluded into a group and see, look what I can do with communication. Look what I can do with my device. I'm new at learning this. I've only been doing it a couple of years, and have some mentors. So I think the future of telehealth is going to be really good. I would like to see it expand even more to look at group therapy from that aspect as well. I hope I answered what you wanted, because I just started rambling right then.
No, I think that's perfect. And I enjoy the in-person as well. But I could see, like for doctor's appointments, if you have 4 doctor's appointments or therapy sessions, maybe doing 3 virtual and 1 in person, could really benefit there. And I agree, the silver lining with all the Zoom stuff and having the connection there. Dr. Overschmidt, have you guys also been doing telehealth?
We did. We had, our offices were closed for about 6 weeks, and so the audiologists were Zooming or calling families to help troubleshoot. A lot of what we do is hands-on, so we weren't always able to, if a child needed a new ear mold, we have to make new ear mold impressions. If we need to make impressions because they've grown. So some things we just simply cannot do via remote services. One thing we can do, or will be able to do very soon, is remote programming. So hearing aids require specialized programming by the audiologist. And so our computer services is making it possible so that our 13 offices will have the capability to do this specialized remote programming. And what it will entail is the client will have a cell phone app on their phone. And through that app, they will, and through the hearing aid programming interface, the audiologist and client will be able to be in what's like a Zoom meeting, and the audiologist will be able to program the hearing aids without the client being there, which is really going to be helpful for a lot of our families. Some of our younger children, it's probably, it's not really best practices necessarily to just make a lot of adjustments to their hearing aids without verifying with some specialized equipment that measures the output of the hearing aid in their ear. But for a lot of our older clients, I think it'll be really helpful for.
Yeah, technology. Our phones, I heard somewhere that our phones today have more technology than when they put the first people on the moon.
Makes sense.
All the NASA that put people on the moon, our phones are more powerful than that. Well, as we kind of wrap up here, are there any upcoming events or seminars that you would recommend that parents get involved in?
So I sent some links for you to put up. I'm a big fan of the annual Alabama Autism Conference that's at the University of Alabama. And now you may be sitting out there in the audience going, my child doesn't have autism. Why are you recommending that? It's a really good general conference. It's especially good for parents of children with autism. It's upcoming February 25th, 2022. Our Family Voices of Alabama, our Family Voices Partners in Care Summit, usually held at the end of April, beginning of May in Prattville at Robert Trent Jones. And it's been postponed for right now, but they have really good family engagement. And actually the first day of the conference is for families in the evening, and professionals don't even attend that. And I think that's a good way for families just to meet and network with one another. But just always, anything that you're attending, be mindful of where the presenter's perspective is coming from, and if they have if they're financially vested in something, just to not be sold on something until you investigate yourself.
Yeah. So there are 2 good conferences coming up. Dr. Overschmidt, is there an upcoming seminar or any event that you would recommend families get involved in?
Sure, and I'll send you those links. The Early Intervention Conference, they usually have that every October. As far as I know, it's still on. Also, there is AIDB is sponsoring a conference called Unplugged Real Connections Retreat. It's for families of children who are deaf or hard of hearing, or other professionals that may be interested in attending. And then we also have early hearing detection and intervention learning communities in Mobile, Birmingham, and Huntsville. If anyone's interested in those, it's can be for parents who have children who are deaf or hard of hearing, or professionals that are interested in helping educate the communities about the importance of early hearing detection and intervention. They can reach out to me. You have my email address, and I'd be happy to get them in contact for those communities.
I'm hoping as we get out of this pandemic, the conferences start up again. I enjoy going to them and meeting other people. Well, as we wrap up here, is there anything that we haven't talked about that you think a child or a family member would benefit from hearing? Mrs. Cleckler.
Glad you brought that up, because as we were talking about conferences, all of our districts throughout the state of Alabama, we have the state divided into districts with Children's Rehab Service, and they all have parent advisory councils. And so they call them PACs, Parent Advisory Councils, acronym is PAC. And so there are PAC meetings, and there are also youth advocacy meetings. I know you've had Sarah on, and she was our youth consultant previously. And just calling your local office, you don't even have to be enrolled with CRS to attend a PAC meeting and join in. And those parent consultants do a really good job of finding guest speakers or knowing about locally where you live, what's going on or what resources are in the area, or smaller conferences or meetings and trainings. And so I think that's a really good local resource to get plugged in with.
Mm-hmm. And Dr. Overschmidt, is there anything that you would recommend or that you think children and family members could benefit from hearing?
One thing that we didn't touch on are communication options for children who are deaf or hard of hearing. And sometimes that can be a bit of a touchy subject. But if anyone wants information about the communication options, I can send them. Early Intervention developed a pathways for families of children who are deaf or hard of hearing. It's a huge notebook with a plethora of information. I can send them a physical copy, or I have it, they actually now have it on a PDF file. So I'd be happy to send that out to anybody who's interested. It has a lot of information about the different options and the pros and cons of each.
I feel like we've gone over a wealth of information. And so what we're going to do is we're going to go ahead and timestamp a lot of these talking points so that people can digest the information a little bit easier. We're at about an hour and 20 minutes today, so we'll chop it down into smaller videos. But what I'd like to say on behalf of Alabama Care and the community here is thank you for spending the morning with us and educating us on what exactly your fields are and what parents can look forward to in those and interacting with them. So once again, thank you very much. And at this point, we'll go ahead and end the live broadcast, and we'll all kind of give a wave to the community. Say, see you guys tomorrow.
Thank you, Alex.
Thank you both.
Hi, thank you.